Hello, everyone. First, thank you very much for inviting me to present our results in this forum. My name is Juan Molina Collada. I'm a rheumatologist working on Gregorio Marañón University Hospital in Madrid, Spain. And during the next minutes, I'm going to present the main results of the study Risk of Cancer After Biologic and Targeted Synthetic DMARDs Initiation in Patients with Rheumatic Diseases and a History of Prior Malignancy, data from the BioBadaSer registry. Well, safety data for biologic DMARDs have shown no increased risk of cancer, at least solid or lymphoproliferative, in patients with rheumatoid arthritis without a history of cancer. However, TNF inhibitors appears to increase the risk of skin cancer, including also melanoma. On the other hand, patients with a history of cancer are routinely excluded from randomized control trials, and as a consequence, data on their safety in these patients are very limited. To date, there are 3 meta-analyses that have studied cancer recurrence or new cancers in inflammatory diseases who started treatment with biologic DMARDs and have found no increased risk of for patients with rheumatoid arthritis or chronic inflammatory bowel disease and a history of cancer. However, data on the safety of targeted synthetic DMARDs in this population is lacking, and none of the studies have compared directly the relative risk between all available therapies. So the objective of our study was to compare the risk of incident malignancy with exposure to biologic and targeted synthetic DMARDs in patients with rheumatic diseases and a prior malignancy. BioBadaSer is a large national prospective observational cohort of patients with rheumatic diseases starting treatment for the first time with any biologic or targeted synthetic DMARD and follow thereafter at the time an adverse event or a change in biological therapy occurs. This registry was first established to assess the long-term safety of biological DMARD exposure. And at the time of this study, that was December 2021, there were 28 Spanish centers with a total of 9,129 patients included. For this study, we have selected only patients included in BioBadaSer with a history of prior malignancy before the initiation of any biologic or targeted synthetic DMARD at any line of therapy. We have excluded carcinoma in situ and also cutaneous basal cell carcinomas. They are considered usually benign cancers. And if the patients had more than one prior malignancy, the most recent cancer was reported. The primary outcome of our study was incident cancer during follow-up. And how did we define incident cancer? As any cancer, new primaries, local recurrence, or metastasis during the exposure, classified according to the Meta dictionary and leading to therapy discontinuation. We have analyzed the rate of cancer per 1,000 patients years and 95% confidence interval. And we have also estimated the incidence rate ratio of cancer in targeted synthetic DMARDs and other biologic DMARDs versus anti-TNF treated patients that we have selected as the reference category. So, at the time of the study, December 2021, BioBadaSer included a total of 9,129 patients. Of them, 352 patients had a history of prior malignancy, and during follow-up, patients we detected 32 cases of incident malignancy, 17 solid cancer, and 14 non-melanoma skin cancer, and 1 patient had melanoma. Well, 70% of the study sample were females and mean age was 65 years old. More than half of the patients had rheumatoid arthritis diagnosis, 15% had spondyloarthritis, and 31% had other rheumatic diseases. Regarding treatment characteristics, 62% of patients used that therapy as the first-line targeted therapy, and the mean time from cancer diagnosis to start of biologic or target synthetic DMARD was almost 5 years. That is in line with the majority of the recommendations. Regarding prior malignancy characteristics, 94% of patients had a non-lymphoproliferative cancer, solid or melanoma, while 8% of patients had a lymphoproliferative disorders, 20 cases of lymphoma, 9 cases of leukemia, and 2% of the study sample had a metastatic cancer. Well, regarding the rate and type of incident cancer during therapy, we detected 32 incident cancer, 9% of the study sample, and the mean time from treatment initiation to the incident cancer was 4.5 years. The overall rate of incident cancer was 27 events per 1,000 patient years. And when we compare this overall rate of cancer between all therapies included in biobatacert, we have found that there were not increase of incident cancer when compared to anti-TNF treated patients. Same data for mortality. We have found no increased risk of mortality between all therapies included in biobatacert when compared to TNF therapies. So, in conclusion, we can say that the risk of incident cancer in patients with rheumatic diseases and a prior malignancy does not differ according to the type of biologic or targeted synthetic DMARD exposure. The mortality rate does not differ significantly in patients exposed to JAK inhibitors, anti-CD20, anti-IL-6, abatacept, or anti-IL-17 versus anti-TNF therapy. However, these results need to be confirmed in further long-term registries. Well, I just wanted to thank all Spanish rheumatologists who have contributed to the biobatacert registry. And I also would like to thank all of you for your attention.